Okay, so next is applied surgical anatomy, and the first topic is breast reconstruction. So a woman with cancer at 9 o'clock position of the left breast wants breast conservation. So what are the factors that would influence this lady's suitability to breast conservation? So again, it's a universal question. It depends on the size of the cancer, multifocality of the cancer, size of the breast, and the extent of in situ disease. What are the broad oncoplastic approaches to repair the defect after the wide location? This is either volume displacement or volume replacement. As the word indicates, can you explain the difference in these approaches? So volume replacement involves transposition of autologous tissue from outside the breast into the wide location defect. So we have replaced some tissue outside the breast. And volume displacement involves using the remaining breast tissue to fill the defect resulting from the void excision. The patient is deemed to be suitable for the breast conservation. What are the physical parameters that you would measure during your aesthetic assessment of this woman's breast? First of all, patient's height, weight, that will be BMI. Then you have to measure the breast width and height. Then you have to differences in the level of inframammary fold, distance between the sternal notch to the both nipples, distance between the midclavicular point to the both nipples, distance between the nipple and the midline for both breast, distance between the nipple and intermammary fold for both breast, nipple, distance between the two nipples, the diameter of both nipples, the distance from the most medial point of the breast to the midline, and projection of the breast and the degree of the breastosis. In your assessment, this woman's breast is similar in size and defect from the void excision is likely to be significant. You decide to perform a volume replacement procedure to repair the defect. What are the broad types of tissue flaps that you can raise? Give a description. So there is two options, either random skin flap or a pedicled flap. So in random skin flap, a tissue flap consisting of the full thickness of the skin and subcutaneous tissue, the flap is connected by the skin bridge to the surrounding skin. And a pedicle flap, a tissue flap consisting of full thickness of the skin, subcutaneous tissue with or without underlying muscle. The flap is attached to the body by a vascular pedicle. To have the blood supply for these flaps. So random skin flap blood supplies from the subdermal plexus, which is a network of vessels rather than from a longitudinal artery, and pedicle flap blood supplies from the defined blood vessels. You have decided to perform a lateral intercostal artery perforator flap. What are the steps in performing lateral intercostal artery flap repair of the breast defect? So pre-op, we will do a surgical marking in a standing position and lateral breast crease and anterior border of the latissimus dorsi muscle marked. Lateral chest wall perforator is identified and marked using a handheld Doppler, and the remaining flap is drawn with an account of perforator position, size of the flap required, and the skin laxity. Operative, the positioning of the patient full lateral position or supine position with a tilt, lateral breast skin crease incision, wide excision of the tumor, confirm perforator with handheld Doppler, pedicle dissection and confirming vascularity, flap dissection and flap inset by turning over 180 degree or by rotation propeller, and the skin closure. Thank you.